But in the meantime, I'll go ahead and get started. So, quick talk on how do you approach acute liver failure? It's an ICU perspective. So, you know, I'm sure a lot of you have had this talk in regards to either from an emergency medicine perspective or an internal medicine perspective. And, some of it's more medicine focused. I think we'll revamp a lot of this to make it, you know, how do we think about liver failure in the setting of the ICU, especially when they're entering the ICU, and then also kind of like where they are going from the ICU, because a lot of few different things can happen. Um, so, we could just ignore the practice questions because we'll kind of go over them, but this is kind of what I'll be going over. And then the first one, obviously, is thinking about when do we think about acute liver failure? Now, this is not that patient that has chronic liver failure, and generally, it's not your alcoholic patient. So I'm not talking about the patient that's constantly in and out of the ICU because they're in decompensated cirrhosis. They live pretty much jaundiced. They've known for a while that they're not a candidate for liver transplantation. It's not your patient with NASH who's constantly, again, in and out of the hospital because they're getting, frequent paracentesis every 2 weeks and have had, repeatedly weight gains. They come in for a paracentesis or diuresis. They have frequent metabolic shifts. They live with a low bone marrow production. I'm not talking about that patient. I'm talking about the patient who has acute liver failure or acute on chronic liver failure. I'm talking about the patient who you get a rapid response because someone on the floor had a seizure, and then you go to evaluate them, and you have no idea why they had a seizure, but then you get labs and they have like an ammonia of 2 to 300. I'm talking about the patient that presents to the ER who has every lab abnormal and they're altered because the ER couldn't figure out why. They went ahead and intubated them. I'm talking about that patient, or I'm talking about the patient who presents with, you know, an acute portal vein thrombosis, something like that. Sorry, hepatic vein thrombosis, and now the liver function is completely gone. Now they're acutely volume overloaded from the waist down. That's the patient I'm talking about. So yes, you can have acute on chronic liver failure. So meaning that your acute alcoholic patient who's been fine, but something else happened, and now their liver is acutely failing because multiple things can be happening. Or you can have the chronic patient with NASH who, for whatever reason, took too much Tylenol and now has acute liver failure on top of that. Generally, ways you can classify this is you can talk about hyperacute, acute, or subacute with like the time classifications you see below. But the ones that are very, very sick um, is anyone who has an acute decline in liver function. So yes, your hyperacute patient is the one that's very, very sick, but generally, if you're able to catch it early, they're the ones that do well. So if you can figure out that yes, this person took too much Tylenol and that's why they presented to the hospital within a day or two, and now they're very sick, they're the ones you can save. The ones who have that subacute presentation, that maybe for whatever reason their liver has been slowly dying, and then something acute happened to really change their time course, those are the ones that generally were not as successful in saving. They're the ones that will get intubated after watching them for a few days, and then right there and then that once they get intubated, they're very unlikely to come off the ventilator. So when I think about definitions of how do you pick this up, you think about what has caused liver function to be impaired. So when I ask, when I say patient has elevated LFTs, the patient's in liver failure, I'm not talking about your AST and ALT because inherently those are not measures of liver function. Your measures of liver function are your INR, your bilirubin, because these are things that your liver produces. So I challenge you that next time you guys are on rounds and then you hear that, okay, the LFTs are elevated, but you see a normal bilirubin, you see a normal INR, and yes, your transaminases may be elevated, but those aren't measures of your liver function. So I dare you to stop around and say, well, actually, the liver function is fine. The patient is maintaining okay, which means they're clearing ammonium. Their synthetic function, like their INR, is okay, and their bilirubin is normal. And so, in someone to be in acute liver failure, they should have some level of encephalopathy. They should have an impairment in liver function, your INR, your bilirubin. And this can be on top of an elevated transaminases, or they've already burnt out their liver cells and they're not having elevated transaminitis. So meaning their ALT, AST could be normal, but they could still be in acute liver failure. It's a very important distinction to make. And so when you think about that patient presenting acutely, yes, they may have jaundice, they may have some hepatomegaly, they may have some ascites, but the big thing that I'm looking for is signs of hepatic encephalopathy. and then we can actually grade that hepatic encephalopathy. So the way I think about it is, you can obviously go by grade 1, 2, 3, and 4, but the way I think about it just in my head, so I remember it at bedside, and I think about it at bedside because it's a rapid response where I get a consult for it. Grade 2, 3, and 4 should really be in the ICU. And once again, I want to really stress this point. Grade 2, 3, and 4 should really be in the ICU. So grade 1 is that patient who's just a little drunk, right? They've slurred their words, they're not sleeping as good, they've got a change in behavior. Grade 2 to me is someone that got a little too drunk. Now they're starting to get a little more confused and a little more lethargic, right? They're barely able to make them stay awake. Grade 3 to me is the one that has taken too many opioids. It's all down, down, and down, right? They're not arousable. Their speech is very like mumbled and quiet. They're not very responsive. And grade 4 is the one that has overdosed on opioids. They are no longer responding. They are out. They're in a full-on coma. And so what's happening here is think it's all about the ammonium. It's all about the osmotic shifts. The liver, one of its functions is to metabolize it and clear it through the gut. The liver can't do that. The body can't clear it through the gut. And instead, what happens, it builds up. And because of the form it's in, it's able to cross the blood-brain barrier. And the more and more it crosses the blood-brain barrier, the more osmotic shifts you have. Just like we freak out about sodium, we're freaking out about ammonium. And so it causes these osmotic shifts, and eventually it gets bad enough. And then you get these neurological symptoms. You start to get asterisks, which in grade 4 you're not going to see because the patient's out. You can get seizures, which obviously if it's difficult to detect because the ER already intubated them, and that's going to be hard to see. The thing that I care about the most is, once again, those osmotic shifts. And the more shifts that happen, the more edematous you become. So I'm taking my ultrasound and I'm putting it to a patient's eyes if they're out, and I'm measuring intracranial pressures. And I'm doing that in the way of Doppler ultrasound. I'm looking at their vitals. I'm seeing, are they possibly hypertensive? Are they possibly bradycardic? Are they possibly apneic? Keeping in mind that you will only see Cushing's triad in the most severe cases. What you might see before that is you'll start to see marked fluctuations in their blood pressure. 1 minute they're hypertensive, the next minute they're hypotensive. And immediately I'm concerned about increased intracranial pressures. So once again, patients who have hepatic encephalopathy, who you're concerned because of acute liver failure, not your chronic HE patients, but acutely, you should really bring grade 2, 3, and 4 to the ICU, even if they look okay at that point, even if at that point they're just lethargic, and you know what, you see that their ammonia is high. Because all of this happened acutely, the chances of you being able to reverse it with lactulose, with rifaximin on the floor, is less likely. And before you know it, they will get worse, and then you'll be intubating them emergently and removing them to the ICU emergently. Much rather to be asked for, much rather be better prepared and have them in the unit than be trying to resuscitate them on the floor. And so, other things that you can see in the physical exam, usually more with more chronic liver failure. And I'm not as concerned. The thing I care most about is a patient that has intravascular volume depletion. I'll get to that in a second. Why? Because now resuscitation, when they're dealing with everything else, becomes an issue. And so what I'm seeing when I'm looking at their intravascular volume status is that they're, whether they're bradycardic or tachycardic, is that I see their IVC completely collapsible. I see that their central venous pressure is very low, either measured with ultrasound or when I'm trying to go put that IJ in, or even just trying to get peripheral access, I'll quickly put that probe to the IJ and I'll see that it's very, very collapsible. And likely what's happening is that because their liver is no longer able to produce their synthetic function of albumin, all that intravascular places is intravascular volume is leaking out and third spacing. And so you know that when you're resuscitating these patients, that they might not be your usual resuscitation where you're giving them a fluid bolus, because what's going to happen? There's no albumin or protein keeping it in, so they're going to leak out, and your blood pressure is going to go up and then down. And then when you intubate, you're going to start having hemodynamic issues. So yes, in this patient, I'm generally considering albumin or hypertonic saline. And there is some data for hypertonic saline. I know not a lot of people are a fan of it, but yes, at least consider albumin over fluids. And so when I think about lab abnormalities, once again, it's that INR greater than 1.5. I'm looking at the trend in the INR and elevation in bilirubin. I'm seeing thrombocytopenia because their bone marrow is not being stimulated to produce anything. I may or may not see elevated transaminases. So I don't have to see elevated ALT to elevated AST. And really the one that really portends a poor prognosis is their bilirubin. And so, yes, if you guys are thinking about calculating a MELD NA score, that's a great score because that helps you think ahead about destination, about survival. But in the acute setting, when you're resuscitating this patient, it's not going to be that helpful for you because the damage has already happened. And so I think where the MELD NA score is very useful is in the first few days of taking care of this patient, is which way are they trending? Is what you're doing having an effect? And it's really not dependent on what you're doing. It's really just how far along the body has gone. But that's where you kind of decide. Now, patients with an elevated INR, everyone freaks out. Oh my God, they're going to bleed. They're going to bleed. They're going to bleed. I need to put a central line in. Let me reverse this. Maybe the patient has an emergent surgical issue. The INR is elevated. Keep in mind that in cirrhotic patients, so your patients that are presenting with acute on chronic liver failure, they are generally hypercoagulable, meaning that they are more likely to clot. And what's the evidence for that? We took all these cirrhotic patients with an elevated INR, and we looked at them with, whether they bled or they were coagulable, and you compare them to patients that were not cirrhotic or that had an elevated INR not due to cirrhosis. And what we found was, I forgot to add the screenshot, is that patients who had cirrhosis compared to patients with an elevated INR not due to cirrhosis had a much higher incidence of clotting as compared to bleeding. So there were still patients that bled, but there was a much higher percentage of those patients that were actually dealing with clots instead of bleeding. And then there were a subset of patients that had issues with both. And so what the TEG showed when they compared thromboelastography, and remember keeping in mind that TEG is also not foolproof, it has its flaws, is that on that cascade, they saw that patients were actually hypercoagulable instead of hypocoagulable. And so generally, this is why when you're thinking about a paracentesis for your cirrhotic patients, the IR Society, the GI Society, the HEMOC Society, and the Critical Care Society all recommend not checking an INR in patients who have cirrhosis because it's inaccurate and it should not in any way delay any procedures. So I'm definitely not trying to treat this. Yes, fine. If the proceduralist is adamant about it and they require this life-saving procedure, I'm going with what the proceduralists say. But generally, if it's my choice, I am not treating it. And I'm, once again, my approach to cirrhotic patients is different than my approach to acute patients. Other thing that you may see, acidosis or alkalosis, metabolic derangements, hemolytic anemia can be pretty common. So if you're getting a downturning anemia, make sure you guys are not behind the eight ball and work that up. I generally ignore the urine electrolytes. I think that's more of an urine electrolytes. I generally think that's more of an academic exercise anyways. If the patient has stabilized for a few days and I'm still trying to do a workup, or if my ultrasound has failed me, and I'm not able to get a good assessment of volume status, then maybe I'll consider it to see what's exactly going on with the kidneys, because I don't want to be behind the eight ball on trying to recover their kidneys, because hepatorenal syndrome in these patients happens more often quickly than not. And it's a scary hepatorenal, the type 1 hepatorenal, not the type 2. The other thing to keep in mind is that ammonia, and I think I'll send out a thread on why generally the serum ammonia is not that important to me unless it's insanely high. So, if it's greater than 150, fine. This patient likely has it, but I don't need an elevated ammonia level to make the diagnosis, because the ammonia level is measuring what's in the blood, not what's in the brain. And we as humans get dramatic shifts in our ammonia levels with protein diets, right? So you can have a heavy meal and it could go up depending on your body's metabolism, but you're not going to be dealing with hepatic encephalopathy because your liver will eventually be able to metabolize it. But if you've been elevated for a while and then all of a sudden you're now getting malnourished, your ammonia level may be low, but the damage to your brain has already been done, based on your ability for your liver to clear it. And so once again, we kind of already talked about this chemistry test versus functional tests. This is what we care about. Yes, if it's insanely high, they may in a few days, if your ALT, AST is insanely high, then in a few days your LFTs may start to go up because it's behind the eight ball. And so, yes, in some settings, it can, if you're catching them in the acute phase, some patterns, which are more helpful for boards, can be helpful, right? So, for example, we talked about your alcoholic patient who's got notable elevation in AST over ALT. That's usually more chronic, but yes, in the acute hepatitis phase, meaning when they're just completely destroyed their liver from a pretty big binge, your AST may be very, very high. We talk about Tylenol overdoses. Initially, generally what you see is that the bilirubin function is low, but your INR and your liver chemistry tests are insanely high. Ischemic hepatitis, which includes the same damage that will happen from congestive hepatitis, so your shock liver. Um, Keeping in mind that someone with really bad heart failure, that's generally more of a chronic presentation. They'll have insanely high liver chemistry tests, and their LDH will be high because they're getting really bad ischemia in the liver. And so you get this overt production of LDH as a sign of the cells dying. Um, and then you have hepatitis. Different viral issues have different patterns. Obviously, it's been studied. Once again, the ones I care about, you can see a pattern here, very, very high elevated liver chemistry tests. In viral panels, generally the ALT, the alive liver enzyme, L for alive, is generally more higher, maybe twice as much as the AST. And then if I'm thinking about Wilson's disease or obstructive causes, I get that market elevation in alk phos, but that elevation in alk phos without the elevation in bilirubin, that's when I'm concerned about something a little more metabolic like Wilson's disease. And there's all these other patterns out there, but regardless, these patients, it's such high risk that I'm generally ordering my full workup anyways. Um, and so I'm ordering that right upper quadrant ultrasound always with Doppler because you want to rule out a thrombotic cause. And remember, they could have something else that destroyed them, like a Tylenol overdose, but because their liver has been damaged and they're now cirrhotic, they may be prone to clotting. And the first place you'll see clotting is in the vessels around the liver, such as the portal vein or hepatic vein. And so if the patient's stable enough, and generally, I'm not getting this imaging for a while because the patient is generally not stable enough, but it's CT imaging because I need to stabilize them first. And a very low threshold to order a Ceribell or an EEG. I'm always ordering an echo. If not, I'm doing one myself. And then, yes, when the patient is stable enough, I want to get high quality imaging so I can properly assess for early signs of cerebral edema. And so, you get this patient, you've made this diagnosis of liver failure. I'm doing a workup. Now, keeping in mind from the ICU, the goal is to stabilize before you diagnose. And so I just have an order set and I order this, and it's usually about 6 or 7 things. I'm looking over all the medications in detail to rule out any drugs or toxins that can cause it. My best friend in this case is livertox.gov. They have a detailed table of all the medications, and I literally go through their medications. And by that, I mean I ask a resident to go through it, and I ask them to enter every medicine that they've been on, either inpatient or outpatient. And I look at the doses that they're getting. And if it's even relatively high, then I have them enter it on the website and see whether it causes liver failure. And then I also look at combinations of medications, right? So if the low dose and if the medication pops up, sorry, on liver tox, because you're thinking about all your stuff that you remembered in med school about like CYP metabolism and all the different enzymes, if they interact, even being at a low dose of a medication can cause toxicity because of another medication. So like what we see on our boards is like the classic patient with who's on an immunosuppressant drug but now has been put on an antifungal. They interact with each other. They can result in acute liver failure pretty quickly because of impaired metabolism. I'm thinking about, your usual causes like Tylenol. I'm getting that right upper quadrant ultrasound. And then generally the other stuff is not going to be as acute. The interesting one to me is, hyperperfusion, the heat stroke, and then HLH, right? So hyperperfusion is your ischemic patient. The damage there is generally already done. Not much I can do about it. The patient with heat stroke, they are very, very sick. They require rapid cooling. Until then, they get these persistent fevers. You're doing a full workup, but then you're not going to be able to make that diagnosis until you get some better ancillary information from what happened before they came into the hospital. And then the big one is HLH. These patients are generally very inflamed, prone to clotting, and they'll usually clot around the liver. Um, and then the infiltration by the tumor, these are also once again more your subacute patients where the mass just got big enough. Now it's causing some obstructive pathology, and they're like pregnant patients. The only way you can resuscitate them temporarily is like you lie them on one side where that mass is no longer pushing on the IVC so that blood flow can flow through the liver. And then generally they don't have much time anyways because the damage again has already been done. They're usually very, very poor surgical candidates. This is exactly what's in my order set that I order. And if you guys want to steal it, you can. You just go on Cerner, you search, the orders and search by name. You can basically copy this over to your order set. Um, but if not, you can find this on any acute liver article. Generally, these patients are not making it to biopsy, right? As soon as I've made the diagnosis of acute liver failure, I am always talking to a liver transplant center, including my alcoholics. And the reason for that is that there's only so much we can offer here. It is part of these, the workup that these patients with acute liver failure to possibly consider an IVD placement, an intraventricular drain placement to measure intracranial pressures, because if they're dealing with an acute issue and once they get them stabilized, these centers usually want this patient there. Now, if they're already intubated and you don't know whether they're going to make a recovery because maybe they have a more chronic process, then yes, fine. The transplant center will say, go ahead, continue what you're doing, resuscitate them. If they improve, call us back. And generally, what I found is that these transplant centers will generally call you back if you forget to follow up because they don't want to be behind the eight ball on this patient. And yes, this absolutely includes your alcoholics. So depending on availability, depending on the transplant list, depending on other comorbidities, some centers will not rule out a patient who has a good support system, who's shown some evidence of trying, that even the patient with acute liver failure due to alcohol, they may be considered for transplant. But it all depends on the comorbidities and just at the timing of when you call. So it's better to call than to not. And then the other reason, obviously, being is that these guys are experts in liver resuscitation. Is that there is some evidence to show that patients are better served at acute liver transplant centers. So even if they refuse, I feel better that I've done what's best for my patient and made that call. And then now it's just other factors of why they can't go. So we talked about what are generally more acute. I'm kind of focusing on that, and the reason that it's important to make the diagnosis of what's causing it is because in some cases you can treat your acute causes. If, for example, anticoagulation, addressing the metabolic derangement caused by things like Wilson's disease. These patients, if there's some other treatment that I can offer, I want to make sure I don't miss it. So even though I've made that diagnosis of acute liver failure, I still have to figure out what caused it as soon as I'm getting, caught up on resuscitation. And so we already talked about transferring to liver transplant center, bringing the patients with grade 2, 3, or 4 encephalopathy to the ICU, and then just making sure that they are on an aggressive regimen. I'm usually checking the orders myself for patients who I keep on the floor. And so when I talk about specific treatments, now the one I want to focus on is N-acetylcysteine. So I didn't attach the papers here because the papers aren't that convincing for it. But I would say that regardless of the cause of acute liver failure, you should absolutely put everyone on N-acetylcysteine. And the reason why a lot of hepatologists will make that recommendation is that because even though it may not be due to Tylenol toxicity, if you don't know the cause, these patients generally do better. If you think about, what happens from a metabolic standpoint, you are supporting the liver. They've used up a certain enzyme that they no longer have. I know we don't have to have a full lecture on, NAC and everything like that, but they've used up an enzyme that the liver is no longer able to produce, and now the liver needs help, and you're supporting them in metabolizing all these other drugs in their body by giving them N-acetylcysteine. And so generally approach is that if it's due to Tylenol, you continue the N-acetylcysteine. Yes, you can use the new Matthew monogram, but generally you're using it as continuous therapy until the Tylenol levels have cleared. Or for those that you don't know the cause, you're using it continuously until they show signs of improvement. And so I reassess after completing each dose, and then I restart that continuous dose. And then I'm continuously reassessing them. And I'm generally, because the dosing can get pretty confusing, I'm calling my pharmacist and doing it with them. And they were on this journey together for the next 12, 14, 24 hours of continuous NAC therapy. And only if there's a good indication to discontinue it am I discontinue it. For example, if I've 100% sure that it's just a clot and no other reason why it happened, then fine, I can consider discontinuing it. Or if it's due to alcohol, I'm discontinuing it. Hepatitis B, yes, you should still put them on antiretroviral therapy if it's due to that cause. So not antiretroviral therapy, antiviral therapy. And yes, there's all this triple therapy stuff. If it's a toxic ingestion and I catch it in time, I can do charcoal. If I'm concerned that it's due to alcohol or autoimmune causes and it's all happening very acute, and that this patient may be more an inflamed liver that's heading towards acute liver failure, then I'm thinking about steroids. Now, it becomes a little more of a mechanical issue. You see that patients with that like Budd-Chiari physiology, if they have a thrombosis, um, with Wilson's disease, important to make the diagnosis because you have an empiric treatment that works, and that's plasma exchange. But you have to think about it early. And so we talked about where each patient is going wrong, right? So this patient is coming in with one issue, but because the liver is connected to every other part of the body, you have to treat each of those ones individually. So we talked about here, right? They what type of shock they're in, right? Like, so this is why we talk about circulatory shock and not about distributive shock, not about cardiogenic shock, not about, obstructive shock, because generally what's happening is that these patients have an inciting factor. And so, yes, their initial cause may be distributive, their initial cause may be cardiogenic, but as these patients progress, other causes of shock happen, right? The patient with cardiogenic shock, because they're not perfusing their organs are dying, they're releasing a bunch of cytokines because the cells are dying. And so now they have cardiogenic plus distributive shock. The patient that is in distributive shock because of a sepsis from a bug is now having septic cardiomyopathy, right? So there could be multiple causes, and that goes same with like obstructive causes. And so the liver is no different, right? The liver is no longer able to clear its prostaglandins, and so you get this overt inflammatory or this overt vasodilatory response, and so they look septic, and yes, you should still empirically treat them with antibiotics, also because the liver is no longer able to produce immunoglobulins. So I consider these patients immunocompromised, and so I'm treating with them with empiric antibiotics, and I'm supporting them to this more distributive cause, but also they're going to be very, very intravascularly depleted, right? We talked about how these patients are just leaking out fluid and third spacing. So very early threshold to start pressors, and I'm generally going for a higher MAP. So there's a lot of hepatologists out there and even nephrologists that will push based on mixed data, and I understand why the data is mixed because these patients are so sick, you're never going to get good data on it. But generally, I'm targeting the higher MAP. I'm going for 75, 85, and I'm doing that for a few reasons, right? So one, we talked about intracranial pressures. We talked about how we want to, if I'm concerned about elevated intracranial pressures, we talked about a few times, I think in prior lectures, that your mean arterial pressure is equal to your cerebral perfusion pressure plus your intracranial pressure. So say you're not monitoring your intracranial pressures, you can use your MAP as a surrogate for what they may be. So if your intracranial pressures are high and your MAP stays the same, you know that your cerebral perfusion pressure goes down, right? So if you think about that equation, MAP is equal to ICP plus CPP. If I target a higher MAP and I am dealing with elevated intracranial pressures, then I am giving myself some room by targeting that higher MAP, whether it's with, likely with use of vasopressors, likely with use of norepinephrine, by targeting higher MAP and by therefore increasing my cerebral perfusion pressures in case the ICP is high. Same with HRS. I'm targeting that higher renal perfusion. I'm trying to maximize renal perfusion, keeping in mind that if you start to go up on pure vasoactives, like neo or vaso, I may be decreasing perfusion to my kidneys. So you have to be careful of that. So as long as you can use norepinephrine, the patient's tolerating it, I would try and stick with norepinephrine. When I think about systemically, we talked about cardiovascular, pulmonary wise, that patient with like hepatopulmonary syndrome, that's usually your chronic patient. But generally, these patients are not able to protect their airway, and that's why I'm intubating them. Now, intubating becomes fun, right? Because what medication do you want to use to resuscitate this patient? You get a rapid response, this patient had a seizure, you look at their ammonia, it's crazy high, or you see other physical exam findings, or you see that they've been on Tylenol, you bring this patient to the unit, or you intubate them on the floor. If you're intubating them on the floor, it's usually so quick that they're already out. You probably won't use any RSI meds, but if you're doing it, in a safe way and you bring them to the ICU, I generally like in this sense propofol because I want to avoid any elevation into intracranial pressures. So I'm protecting myself by using propofol, even if they're hypotensive. And the reason I say that is because in this case, yes, even ketamine may cause a hypotensive state, and I want to avoid any elevations in intracranial pressures. The one to absolutely avoid are benzos because Versed is clear to the liver, so it's going to stick around for a while. And if there's any chance of me trying to assess them, I'm generally avoiding any Versed, especially for sedation after I've intubated them. So in this case, generally avoid using benzos. If you absolutely have to use benzos, I would stick with Ativan because it goes less to the liver and most of the kidneys. These patients are generally so sick, and especially your patients with elevated INRs, or patients who are coagulopathic. I want them on stress also prophylaxis with protonics. Um, I think about these patients as immunocompromised, so they're prone to like fungal infections or like other drug-resistant bugs. So I'm empirically treating them. Low threshold to start antifungal coverage. If they have ascites, doing a uh, paracentesis can take a while if I'm trying to remove fluid, but if I'm trying to get a sample, you can generally take care of this in 2 to 3 minutes, because you're really just putting that needle, you're making the patient sterile, you're putting that needle in, you get your sample, and then you're done. And so yes, you may administer the antibiotics, but you're not going to clear your drug flora from your acidic space if you give the antibiotics and then you decide to do your SP and you decide to do that quick sample. It's still very, very valuable. We talked about coagulopathy, pearls from like chronic or subacute liver patient, you may see that they're so malnourished because they've been less responsive. They may be still responsive to vitamin K because on top of their acute liver filling, they're also just depleted in nutrients. Um, and then generally these patients in that acutely sick setting will deplete all their glucose stores in the liver, and they'll be persistently hypoglycemic. And no matter how much sugar you give them, they're still producing, they're no longer able to produce any more glucose. So, early feeding for these patients, um, initially having to put them on a D10 drip, whatever you have to do. And then finally, there's all this management for what you can do for hepatic encephalopathy or for elevated ICPs. But keeping in mind that it's a clinical suspicion, right? We're being realistic. We're practicing at a center where not everyone gets intracranial pressure monitoring. So figure out ways where you can detect it early and treat it early. So, we're talking about, using osmotic agents, whether it's hypertonic saline, cough, that's better than mannitol. Obviously, look at their serum osmosis, see if it's too high already, because then they may not be a candidate for it. I'm generally thinking phenytoin or Keppra for seizures. I'm doing all my usual ICP elevation management, like elevating the head of bed, trying to avoid placing a line in the IJ because that will again raise your intracranial pressures. So yes, go ahead and put that fem line in, or go ahead and use that axillary area to try and get a line in, because you want to avoid putting anything in their IJ. I think I covered everything here. Oh yeah, so for ammonium clearance, like these are the patients you don't mess around with. The rifaximin will take a while to work. So in addition to lactulose, I really like using polyethylene glycol, and I will use high amounts of it through the NG tube because we constantly think about lactulose rifaximin. That's like a maintenance thing, right? Targeting 3 bowel movements a day, that's a maintenance thing. I'm giving enough until they start pooping, and I want them to be consistently pooping. So if I have to go up on the lactulose, if I have to add a crap to polyethylene glycol, it'll work. Things that I haven't found to work is trying to give lactulose rectally, because usually they're not moving their bowels at all. That is not moving anywhere, and it's just going to sit there. And then this ammonium level, you're going to be behind the 8 ball. Low threshold to consider dialysis for these patients. And the reason I say that is not just for hepatorenal syndrome, but also for ammonium clearance. We talk about, what is triple therapy for hepatic encephalopathy or acute liver failure. So yes, you're considering things like lactulose, but you're also considering things like dialysis to help clear their ammonium, because if you do that, you may be able to prevent that cerebral edema. The caveat to this, and this is where like not much data is there. If it happened chronically, for example, with your cirrhotic patients, they're the ones that will do very, very poorly with dialysis. If it happened acutely, for example, Tylenol overdose, these are the patients that do very well with dialysis. You prevent HRS, you prevent ICP elevations because you're acutely preventing that osmotic shift. But if you're doing it chronically, if the damage happened chronically and you're trying to acutely fix it with dialysis, that's when you deal with your problems. And you guys see the pattern, how that's similar to addressing your sodium. Um, any questions on all that? Cool. So obviously you're going to that liver tox thing, and then by that you're also
Hey,
going to,
Uday,
yeah, go ahead.
could you just touch a little bit on the using hypertonic saline for the elevated intracranial pressures? We kind of I don't were you there the other day for that patient in Mullica Hill where it was really difficult to increase the serum sodium?
Yeah, I mean, I know that there was a patient in Monaco that was put on a hypertonic saline drip. That has almost no utility, right? So, I mean, I have a full lecture on hypertonic saline, so maybe I can save it for then. But generally, what I'm thinking about is that based on the data, hypertonic saline is very effective given as boluses. And if it's not working and I'm not able to try and get that sodium up because I am concerned about elevated intracranial pressures, I'm generally not messing around and I'm putting that central line in. I'm not using 3% saline. I'm using 7.5% hypertonic saline or even 23% hypertonic saline because what I'm trying to achieve here is I'm trying to achieve a quick osmotic shift using a very hypertonic solution that doesn't come with a lot of volume. In order to actively draw all this fluid out from the third space and decrease your intracranial pressures, I want a very osmotic solution given as centrally as possible for it to be effective. So I need that central line in, and I'm generally trying to, as soon as the lab can prepare it, pharmacy can prepare it, that 23% solution. And I'm trying to, and you'll see a response right away. Like in your cirrhotic patients, in your heart failure patients, you'll see an immediate fluid shift of fluid from the extravascular space into the intravascular space, and the blood pressure will go up. And generally, what I found is that it lasts longer than albumin and is more effective than albumin. And if you're considering using an albumin, there's definitely some data, and I'll put this in the hypertonic lecture, of using albumin with hypertonic saline. Um, because what you're really trying to achieve is you're trying to get all that fluid into the intravascular space. What happens in these very vasoplegic patients? Your patient who has liver cirrhosis is not able to produce albumin. What do you guys generally see is that the blood pressure may go up temporarily, right? And then it goes down. And why is that? Is because when you're that vasoplegic, because you're not being able to clear your prostaglandins, even your albumin will leak through the blood vessels and enter your extravascular space. And then what happens? Fluid is shifting more extravascularly. And that's why I really like hypertonic saline in this sense, especially in the resuscitation phase. And really, it's a bridge to dialysis because if I'm requiring it that much, and I'm not being able to successfully clear the ammonium, then generally dialysis is my next step anyways. Does that kind of answer your question?
Yeah, thanks.
And so once again, rely on liver tox, generally the ones that come to mind. So I think about the medications that almost every ICU patient that has some level of encephalopathy is being put on is certain antibiotics, right? So like avoid macrolides because those ones get cleared to the liver. Generally, when I'm thinking about benzos, avoid benzos, right? The patient had a seizure. Your first instinct is to give benzos. Why is the patient having a seizure? If you're going to use it, do not use Versed, use Ativan, avoid Versed drips, avoid benzo drips in general, because when you're thinking about your serial neuro exams to see if they're improving or not, you're kind of shooting yourself in the foot by not being able to properly assess them because you have this medication that's no longer being able to be cleared because the liver's not working. Obviously, Tylenol you want to avoid, keeping in mind that in your cirrhotic patients, your chronic liver failure patients who are no longer in acute liver failure, you can still use Tylenol, just whatever dose you regularly use, cut the dose in half because you still have some synthetic liver function left. But once again, very, you know, very much stressing this is for your chronic patients, not for your acute patients. Um, Generally with opioids, I'm thinking, like I also kind of want to protect the liver a little bit, so I use like fentanyl or ketamine because they're short acting. I don't have to worry about metabolism, things like that. Really, Liver Talks is your friend. It's a great website, easy to use. And so when I think about which way these patients are going, we talk about like it has to be a bridge to something. So when you actually talk to liver transplant centers, you're generally thinking like, is there a chance of recovery here? If there is, then maybe I don't need to transfer them. Versus if they are, if I don't see recovery, if the damage has already been done, these are the patients that should be at a liver transplant center. Obviously, there's so many limitations on it. Far more people acutely need livers than we have, but patients are very quickly moved up the transplant list. Like for example, your classic, the one that generally I see a lot of success is your metabolic causes, your toxins. That's usually not alcohol because once again, alcohol is generally a more chronic process. But if the patient had one acute binge and now the liver's in failure, they may be considered a candidate, especially with a good support system. So all these other things that you guys have seen, I mean, have you guys heard of liver dialysis? It's, I think being experimented. I think Philly, I think Jefferson, I think is experimenting with it. It's called Mars. If you guys want to check it out on your phone, like a picture of it, it's pretty interesting. I think we're still very, 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 very much in the early stages. Basically, what you're doing is you're pretty much doing like, it's the equivalent of like ECMO for the heart. It's like VA ECMO for the heart or VB for the lungs or dialysis for the kidneys. You're doing liver dialysis, right? You're clearing up, you're doing all the synthetic functions of the liver, helping them stabilize their INR, giving them all the immunoglobulins that they've lost, getting some oncotic function back. But generally, these patients are so sick, the data is going to be bad. And, for now, it's all very, very much experimental. If you get admitted at an institution, they may consider putting you on and if they have an active trial going on, they'll put you on liver dialysis, but it's generally not something that patients are being transferred for. Um, and so what helps you kind of decide? Once again, I mentioned the trend in the MELD-NA score is generally very useful, but I really like the King's College criteria. And the reason is because a lot of research papers will help you justify transferring these patients to a liver transplant center because they have an elevated because they meet criteria by King's College criteria. It was developed in Europe, used a lot in research studies out here. If they meet these criteria, I mentioned this to them, and the moment I mentioned that they meet criteria for transfer by elevated King's College criteria, I literally have a pause by the hepatologist on the liver transplant center, and they're like, "Fine, they're sick. Bring them over. We'll take care of them here." And I'm only pushing for them to be transferred over is because I would much rather, even though I can study about all this as much as I can, I am not seeing the same volume of these patients. If there's something that they can offer there, because maybe an ICD elevation, early dialysis, closer monitoring, earlier consideration of liver transplant, or certain medications that they have that we don't, I want them at a liver transplant center. And so once again, just quick pearls from this. Think about synthetic function, not about ALT and AST. Always try and figure out what the cause is. So if you're thinking acute liver failure, yes, your job is to resuscitate before you diagnose, but definitely diagnose because there may be therapies that you may be able to offer that may actually save the patient, that you wouldn't think about unless you went through that entire list. Use liver talks, go through it every single time, not just to make the diagnosis of why they decompensated, but also to figure out what medications they can continue to use. Think about these patients systemically, resuscitate, resuscitate, resuscitate. The big one being, um, you know, yeah, this I think is like your money slide right here. Uh, all these little considerations from the different systems, right? Like early consideration for dialysis, impaired treatment with not just lactose, but with PEG, and I'm considering high amounts of vitamin K challenge, prophylaxis with like, stress cell prophylaxis, antibiotics, and then close monitoring of elevations of your ICP. I think ocular ultrasound is your best friend here because we're not doing a lot of intraventricular drains and the vitals tend to fluctuate. So I'm really relying on the ultrasound. If I'm seeing a ocular diameter greater than 5 millimeters, um, then I'm considering elevations in intracranial pressure. And my immediate treatment after that is being a lot more aggressive with my lactulose and my polyethylene glycol. I already have that NG tube in, and I'm aggressively giving them this medication. And if I'm not seeing any bowel movements, I'm putting in a dialysis catheter and I'm forcing the nephrologist to initiate dialysis because it's the only way you're going to be saving this patient and preventing further increases in your intracranial pressures. Questions?
So Uday, were you ultrasounding everyone's eyes at Cooper last week?
Yes. Actually, yes.
I don't doubt it.
Yeah. Rancon and I were having a lot of fun with that.
Nice.
Yeah. Anyone else have any questions? I think the part that people will generally disagree on is, and you guys will see we do this on sign out as well, is that we'll kind of go over the rapid responses or the consults that you guys had on the floor. You'll get a consult, for the patient that, and I've done this a few times throughout the year. You'll get a consult for a patient that has a pneumonia. They're on the floor. You were told that you went and saw them. They're protecting their airway. They're a bit out of it, but then their ammonia was 400. I'm not keeping that patient on the floor. I'm bringing them to the ICU right away, even if they're, grade 2, just slightly lethargic, not responsive. Because once again, I'm justifying it by saying that, data says that grade 2, 3, and 4 patients should be in the ICU, but I'm being adamant about it because they will turn very quickly. And I think we had a case a couple of weeks ago. There was a patient that had an ammonia of like 300 or 400. They were talking, they were responsive, but they were slurring their speech. They had some asterisks. Um, and so, in sign out itself, the moment I got the sign out, I saw this consult for the patient of ammonia of 300. The attending said it was okay to keep on the floor. As soon as sign out finished, I walked over to the patient and I see respiratory saying about time and asked what happened. She's like, this patient, I just walked by and they're out of it. They're like, gargling them out. And because these patients turn very quickly, you may see them, but the moment you see an ammonia level that high, they should have been in the ICU a while ago, and you should already be talking about dialysis. And so, yes, we brought this patient immediately over. They did have elevated intracranial pressures. We immediately started them on dialysis. We put their EEG on, even though they weren't doing anything. They were having seizures, likely because of elevated ICPs. So we were already behind the 8 ball, and obviously this patient didn't do well. So yes, these patients are very, very, very sick. All right, cool. That's all I have. If you guys have any questions, obviously feel free to reach out to me. I think Joanna's going to go next, and then